The last section of notes for this unit is on blood vessels. You can watch this video animation of a laser vein finder, which is really kind of neat. There are three major types of vessels that create a closed system. And what we mean by a closed system is that the blood is always contained within the vessels. And we usually say that we start and end at the heart, even though it is a cycle or a pathway where there technically is no beginning or end. Arteries carry blood away from the heart. Usually they'll contain oxygen-rich blood. The one exception to that are the pulmonary arteries. The pulmonary arteries are going away from the heart, but they're going from the right ventricle to the lungs. And so they're carrying oxygen-poor blood. Arteries are very thick-walled, and that is so they can withstand extreme force of blood that's expelled from the heart. The heart is pumping with extreme amount of force that if the arteries did not have thick walls, they could potentially burst. Artery walls contain elastin, which allows them to expand and recoil. The pulse or pressure points that we have in different locations in the body are places where arteries are close to the skin surface, where we can actually feel those pulsations, that expansion and recoil. As we get further and further from the heart, the size of the arteries decrease. The aorta is the largest artery in the body, and that is coming directly off the left ventricle of the heart. Arterioles are the smallest arteries. They lead to capillaries, and arterioles are able to control blood flow in different locations via vasodilation and vasoconstriction. So by either opening up or closing off, arterioles are able to direct blood to the locations that's needed within the body. Veins always carry blood toward the heart. Veins usually carry oxygen-poor blood. The one exception are the pulmonary veins. The pulmonary veins are coming to the heart from the lungs. And so they're carrying oxygen-rich blood from the lungs toward the left atrium. Veins are thin-walled. In terms of the circulation loop, they're considered to be far from the heart. So they're not going to experience that extreme force that the arteries do when the heart is pumping. By the time blood gets to the veins, it's more at a pretty regular flow. Veins do contain valves, and valves, just like the valves in the heart, the valves that we find in veins prevent backflow of blood. When our leg muscles contract, blood in the deep veins is squeezed upward. Valves will open to allow blood to successfully circulate. And as blood continues up through the leg, it'll move past valves, and then the valves will close so that there's no back trickling of blood against gravity. Veins increase in size the closer we get to the heart. So the vena cava is the largest vein in the body. That is the vein that is going directly to the right atrium. Venules are the smallest veins. They are the furthest from the heart, and they form from the convergence of capillaries. Veins are often considered blood reservoirs because up to 65% of our blood at any time is located in the veins. And that blood can be mobilized when physiological demands require blood. So if there's certain areas that require more blood, we have that extra blood in the veins that can then be directed to where it needs to be. Capillaries are the smallest blood vessels. They are extremely narrow. They pretty much only allow a single red blood cell to pass through at a time. They have very thin walls, about 1 cell layer thick, and the thin walls will allow diffusion of gases and nutrients, wastes to go in and out of those capillaries for the gas and the nutrient exchange that takes place at our tissues. Blood flow is relatively constant when we're at rest. It does vary widely through our individual organs depending on the needs of our body at that time. So, for example, during cardio activity, our muscles are going to get a greater amount of blood flow than other parts of the body. When we're digesting food, like after we've just eaten a meal, our digestive organs are going to get a greater blood supply than other parts of the body. There are also collateral channels, which are alternate pathways that can supply an area with blood if other pathways are occluded or blocked. So, if blood can't reach a certain part of the body, we're risking tissue death beyond that blockage. So, collateral channels help to prevent that from happening. Vascular resistance is opposition to blood flow. Technically, it's a measure of the friction that blood encounters through the vessels. So, the different sources of increased resistance. So, what's going to increase friction would be an increase in the blood viscosity. So, the thicker the blood is, it's going to have more resistance. Increased blood vessel length. The longer the blood vessel, the more friction it's going to have as it's moving through those blood vessels. And decreased blood vessel diameter. If we decrease the diameter of the blood vessel, then it's going to be harder for that blood to pass through because there's less area for it to do so. An increase in resistance will result in an increase in blood pressure. It'll decrease the amount of blood flow, and it'll decrease stroke volume. Stroke volume is the amount of blood that's pumped from the left ventricle with each contraction. There are 3 things that will affect stroke volume. Preload is the filling pressure of the heart. So, how well can that chamber fill? Contractility is the strength of contraction. How forceful can we contract that chamber? And then afterload is the pressure against which the heart must work to eject the blood. Cardiac output is the amount of blood the heart pumps through the circulatory system in a minute. Normal would be considered to be your entire blood volume, so anywhere between 4 to 6 liters. Cardiac output is going to depend on your heart rate as well as stroke volume. Blood pressure is the force exerted on walls of the blood vessels, and it's measured in units of millimeters of mercury, abbreviated mmHg. It flows in the direction of decreasing pressure gradient. So it's going to go from the arteries to the capillaries to the veins, where we're going from high pressure to low pressure. The differences in pressure provide the driving force that keeps blood moving from higher to lower pressure areas. Blood pressure is also dependent on cardiac output as well as vascular resistance. There are different types of blood pressure. Arterial blood pressure is what we're most familiar with. This is what is clinically measured with a sphygmomanometer and a stethoscope. Sphygmomanometer is the medical term for a blood pressure cuff. So to measure blood pressure, the sphygmomanometer is placed over the brachial artery of the arm. The cuff is inflated until blood flow is blocked through that artery. Then the pressure is released. The systolic pressure is measured first, and that is the pressure reading when the pulse can first be heard through the stethoscope. And those first sounds that can be heard are called the sounds of Korotkov. The diastolic pressure is the pressure reading when the pulse sounds can no longer be heard. So that's how we get the two numbers of our arterial blood pressure. Arterial blood pressure pulsates, which means it rises and falls, which is why we have the two numbers. Systolic is the pressure during ventricular contraction. Normal systolic pressure is about 120 millimeters of mercury. Diastolic is pressure during ventricular relaxation. Normal diastolic pressure is about 80 millimeters of mercury. There are two other types of blood pressure that we don't often talk about. Capillary blood pressure, so the blood pressure that we find in the capillaries, can range anywhere from 20 to 40 millimeters of mercury. Low blood pressure is extremely important in the capillaries because if the blood pressure in the capillaries were too high, it would rupture the thin walls. And then there's venous blood pressure. Venous blood pressure is only about 20 millimeters of mercury, and that's because it's so far away from the pumping action of the heart. Venous blood pressure is steady. It changes very little. We're not going to see pulsations like we do in arterial blood pressure. And valves prevent the backflow during the venous return. Alterations in blood pressure. Our blood pressure cycles normally over a 24-hour period. It tends to peak in the morning. There are other factors that can also affect blood pressure: age, sex, weight, race, mood, posture, and physical activity all can affect our blood pressure on a day-to-day basis, some of which we can control and others we can't. Hypotension is a low blood pressure where it's below 90 over 60 millimeters of mercury. There's different types of hypotension or low blood pressure. There is orthostatic hypotension. This is sometimes called postural hypotension. This is when you feel faint or lightheaded upon standing or changing position suddenly. When you do that, when you change your body position, it can drop your blood pressure. Metabolic hypotension is low blood pressure due to poor nutrition or other metabolic issues. And acute hypotension is caused by circulatory shock. There's a couple of different kinds of shock. There's distributed or vascular shock, and that is when there's extreme vasodilation of the blood vessels. And when that happens, there's less resistance, and so blood pressure drops. The other is hypovolemic shock. This is when you have low blood volume. And this is typically when you've lost more than 20% or 1/5 of your body's fluids. With less fluid to pump, the blood pressure decreases. What tends to be more of an issue is hypertension. Hypertension is sustained arterial pressure of 140 over 90 millimeters of mercury or even higher. Now, transient elevations are normal. So we're going to have periods where we have a higher blood pressure than other times caused by fever, physical exertion, emotional upset. That's normal. Chronic elevation is what's serious, and that's what needs to be monitored and treated, because chronic elevations are the cause of heart failure, vascular disease, renal failure, and stroke. There's two main types of chronic elevations or chronic hypertension. One is called primary or essential hypertension, and that's when there's no clear cause, but it's linked to diet, obesity, age, race, heredity, stress, smoking. So that's where you try lifestyle changes to what degree you can. And then there's also usually medication that needs to be taken as well. Secondary hypertension is caused by another medical condition. So your hypertension may be caused by diabetes or kidney disease, thyroid problems, tumors, where in the case of secondary hypertension, if the cause of that medical condition is dealt with or stabilized, that secondary hypertension then will go away. Blood vessel disorders. So the first is atherosclerosis. Atherosclerosis is when there's buildup of fatty plaque deposits on the inner walls of arteries. As this plaque builds up, it obstructs blood flow. It means that the diameter of the blood vessel in which blood can flow through is narrower, which is going to increase resistance. Furthermore, the plaques may rupture, so they might actually start breaking pieces off, and they could result in thromboses, they could result in blood clots. Risk factors for atherosclerosis: high blood pressure, high cholesterol, diabetes, obesity, tobacco use, lack of exercise, and an unhealthy diet. A lot of things which we do have control over. Another blood vessel disorder is an aneurysm. And an aneurysm is when we have abnormal ballooning and the weakening of an artery wall. There's different types of aneurysms. A fusiform is when we have a bulge on all sides of the artery. A saccular aneurysm is when there's a bulge on only one side. The most common locations for aneurysms are the aorta, the brain, the leg behind the knee, the intestine, and the spleen. Risk factors for aneurysms are high blood pressure, high cholesterol, and smoking. What is so serious about aneurysms is that there's often no symptoms. Oftentimes, an individual who has been identified as having an aneurysm was being checked for something else, and the aneurysm was caught as they were getting something else checked out. The risk of death after a rupture is high, and that's because we're dealing with an artery that is supplying a lot of blood. And so if there's a rupture in that artery, there's going to be an extreme loss of blood. Treatment is surgery to try to reinforce that artery wall in some way. There are three main surgical treatments. Clipping is the placing of a tiny metal clip on the neck of the aneurysm. Endovascular coiling is guiding a platinum wire into the aneurysm. That wire will coil, it'll disrupt blood flow, and then seal the aneurysm. Or endovascular stent. This is when a stent is guided into the aneurysm. Once the graft is in position, it reinforces the artery wall and then prevents the aneurysm from bursting. So you can see the endovascular coiling, clipping, endovascular coiling and a stent, or just the stent. So different treatments depending on the type of aneurysm and the severity. Another blood vessel disorder is venous insufficiency. These are conditions resulting from weakened, damaged, or incompetent valves. And most often we see venous insufficiency in the legs. Spider veins appear as small, thin lines that are either blue, red, or purple. These are usually painless and non-harmful. So they are noticeable on the skin surface, but usually there's nothing to be alarmed about with spider veins. Varicose veins, this is more serious. Varicose veins are larger and deeper than spider veins. They appear lumpy or twisted. They can be flesh colored or red, and there can be many complications with varicose veins. There can be pain, itching, bleeding, swelling, blood clots, and circulation problems.